My name is Michelle Montoya, and I run the compliance department here at Filice Insurance. There's a lot of new stuff to go over this year. California was pretty exciting in terms of all the laws they passed in December. So I want to make sure that you're all caught up on that, and I think it's going to be a really good event. So where are we right now? Current state of healthcare reform. The law was signed in 2010. It's working on its 2-year anniversary. With it, numerous consumer protections have been put in place already. You can keep your kids on until 26, no more pre-existing condition exclusions for children. They're starting to work on closing the donut hole. There's increased preventative care for seniors, that sort of thing. So a number of very good consumer protections have been put into place. The group insurance market, though for many of you, it has been a bit of a hassle from an HR benefit side to get a grip on healthcare reform, what's going to be required. There were some plan modifications. But for the most part, the group insurance market has not changed. The renewal process is still the way that it was. But the individual and employer mandates kick in 2014. And so that's when there is, of course, the potential for big change. And of course, the law faces significant political opposition. So I think that's kind of putting it mildly. And that's kind of what we're going to talk about a lot this morning. So what are some things that you don't have to worry about? Over the last year, they have repealed or delayed a number of things that were in the law, and these are probably all good choices. The first was this 1099 reporting requirement. This was going to be the requirement that as an employer, you would have to do a 1099 for all of your vendors and the same way you do your service providers. It was going to be very onerous. That has been repealed. Don't think we're going to see any version of that coming back. The other thing that was repealed with last year's budget negotiations was this concept of a free choice voucher. That was going to be if you had an employee that didn't like your health plan, you would have to give them a voucher so that they could take the money that you were going to pay and take that to another plan, the exchange, that sort of thing. That has also been repealed. So that's going to go away. Don't think we're going to see another version of that. The Class Act. This was the long-term care program. That was the federally funded long-term care program. They came out this year and basically said there's no way they were going to make this work with the money. And so that has been suspended. And there also is no expectation that that will be revived anywhere in the near future. One of the things that's been delayed that we'll probably hear more about this year is this concept of summary of benefits and coverage. This has been delayed. This is the requirement that an insurance company will put together there's going to be a set of documents that explain what your health plan covers and doesn't cover. So it's going to give scenarios. If you were to have a heart attack, this is on average what it will cost. In your area, this is what this plan will pay, this is what this plan would pay, this is what you would be required to pay, that sort of thing. The first drafts of these came out last fall. They weren't bad, but they were pretty onerous. I think they were like 4 pages each, and if you have 4 different plans, that's a lot of paperwork. The requirement for this has been delayed till March, but even in the final Q&A, they said you don't need to worry about it till they come out with the final regulations. So from a fully insured employer perspective, you don't need to worry about this till your carrier sends them to you. There's nothing you need to do here. As you will eventually be the one that's required to distribute these, but you're not going to need to create them or worry about it until the carriers finalize them. Those of you that are self-insured, you're going to have to do a little more work into this, but I am sure that when the final ones come out, they're going to give us templates to work with, and we'll be able to help you get those in place. So been delayed, don't worry about it till it comes out. The other thing that's been delayed that I don't actually think we're going to see much about actually until 2014 is this concept of the non-discrimination provisions. What they did as part of the law is the whole concept is they want everyone to have equivalent benefits. And so they came out and said that fully insured plans are now going to have to provide or follow the same non-discrimination rules that self-insured plans have had to do. And basically, you're not going to really be able to break employees out and have different benefits for different groups of employees. You can't have better benefits for your highly compensated employees than you have for your lower compensated employees, which in theory sounds nice, but you know from a very realistic business reason, you often break your employees out by class. There's reasons you have different benefits for the people in the offices than maybe the people in the retail shops or the plant. What we're waiting for here is for the IRS to define how you can break employees out by class. So that's what wasn't defined in the law. We're waiting on the IRS to do that. I don't perceive that they're in any big hurry to do this. Even when they do, everything that's kind of come out along this line, they've given you a year from when they put out the final regs, and then you have your renewal date after that 1-year anniversary. So again, I don't think this is going to significantly alter anything, probably until 2014. So, again, don't worry about that till the final regs come out. All right, so what are some things that they did get done this year? The first thing is the concept of these medical loss ratios went into effect. These went into effect actually in January of last year, 2011, and what the law said is that insurance companies have to spend anywhere between 80 and 85%, depending on the size of the group, of what they collect on actual claims. So all of their administrative fees, all of their security technology, all of this kind of stuff, everything they pay their employees, cannot be anywhere more than 15 or 20% of all the money that they collect. By June of this year, they have to provide reports stating that that is been correct, and if they collected any more money than that, they have to rebate this money by August of this year. So this will be interesting because there's some estimates about how much money will be rebated, and I think it's kind of abstract for everybody in this room until you actually get a check or a statement from the insurance company. And if it's a little bit, I think everyone, that happens. If it's a huge amount of money, like some of the estimates are, I think the American people are going to wake up and start thinking, maybe somebody's making too much money. Really just depends what perspective you come at this from. But this will be interesting this summer as reports start coming out as to what kind of rebates are being issued. The other thing that was done is some amended guidance for claims and appeals. Basically, the Department of Health and Human Services came out with better guidelines about how insurance companies have to handle appeals and claims from their members. This wasn't huge in California because a lot of these protections are already in place in California, but it did kind of streamline the process. The other thing that happened this year is the ERRP, the Early Retiree Reinsurance Program, has officially closed down due to running out of money. So kind of like the cash for clunkers thing that seemed like a good idea until they ran out of money in a matter of months, kind of the same thing here. They closed off applications in May, and they're not making any more reimbursements for any claims after December. So I don't know if we'll see any revival of that. I mean, it apparently was successful enough that they ran out of money, but it may be a little too costly in the long run. Some new guidance was put out about the exchanges. Doesn't really affect you from an employer perspective yet, but the states have been given much more freedom or flexibility than maybe they had initially anticipated. They're kind of working back and forth between the states and the Department of Health and Human Services, who definitely don't see this, eye to eye. But a lot more guidance has been put out. Also, some dates have been laid out as to when open enrollments and that sort of thing will be. And I do refer to those in the spreadsheets. And insurance rate reviews went into effect. So this is another interesting thing. So what they did was the Department of Health and Human Services has said that if an insurance company is going to do a rate increase in the small group market or the individual market of over 10%, that has to go under rate review by the Department of Health and Human Services, and if you have somebody with that authority in your state, and they have to rationalize why they're going to have the rate increase that they're going to have. And then the Department of Health and Human Services can either agree with that rationalization or not, but they don't have any authority to say, no, you can't do it. That can only be done at the state level, but I think the goal is to kind of shame them into not doing it, because if the HHS doesn't agree with the insurance company, then the insurance company has to post their rationalization for their big rate increase on their website and the HHS website. So that has just recently kicked in. I'm going to talk about some stuff that's been going on in California. There has been some successes with this. Not massive success, but some success with this. So I think we might start hearing more news about that as this becomes more prevalent this year. So, 2012, what are some things that is going to happen in 2012? The first one is that comparative effectiveness research fee went into effect for all plans that renewed after October 2nd. So for most of you, that was your January 1 renewal. Your insurance company, if you're fully insured, or your company, if you're self-insured, has to pay $1 per member per year to this trust that's being set up. It's a nonprofit corporation, and it's designed to study clinical effectiveness of some of the procedures. So the drugs, the procedures, the surgeries that are happening, the kind of care that's provided, they want to start studying what works and what doesn't work. And, you know, people, this is a kind of politically fraught, of course. You know, no drug company wants it studied and pronounced that their drug doesn't work, obviously. Doctors are a little scared that they're going to come out and say, hey, this procedure doesn't work, and insurance companies are going to stop paying for it. So this is all, you know, fraught. But I'm of the belief that any more information we have about what works and doesn't work is good for you medically in the long run. This just went into place. It's just getting started. We probably won't hear any research news out of them till somewhere towards the end of the year. But this is in place. They're going to start looking, and it kind of ties in with the whole thing with electronic medical records that I'll talk about in a couple more minutes. The other thing that affects you much more directly is this W-2 reporting requirement that goes into effect for large employers as of January 1 of 2012. So what this is if you are an employer that filed 250 or more W-2s for 2011, you then have to put the aggregate amount of an employee's, the cost of their health care, on their W-2 for 2012, which means you don't really have to do this till January of 2013. Some payroll providers have been a little more on top of this than others. I think probably best practice is to have started it right in January, because then you can track, like, if people go on leave or they're not on the benefits or all of that sort of thing. But if you want to wait till December and you're not ready to do this, you're more than welcome to do that. So again, if you filed 250 or more W-2s in 2011, then you have to do it for 2012. The aggregate amount is basically the total cost of the health plan. So it's the amount on your Blue Shield, Blue Cross, Kaiser invoice, the amount you pay plus what the employee pays. It doesn't include dental and vision, HSA contributions, that sort of thing. The dental and vision would only be if they're tied to your medical plan. So if you're enrolled in the medical plan and you're automatically enrolled in the vision plan, then it would count in that dollar amount. If not, if they're unbundled, it's just the pure invoice amount. So if you don't have anywhere near 250 and you didn't do 250 W-2s for 2011, you do not have to do it. And the reason that is they wanted everyone to do it. There's some obscure thing in the tax code that the IRS is not allowed to force employers of less than 250 to file electronically. So that's not going to change for some employers until the IRS changes that code to it. So yeah, if you're under 250, you don't need to do it. Now, it's not, if you believe that maybe your employees aren't really, they have no clue how much their insurance actually costs them, it's not a bad communication tool. So, you may want to take that excuse to do it anyway. All right, again, they're not being taxed on this. This is purely for reporting purposes because the federal government, frankly, has absolutely no clue how much people are paying for health insurance. It's not reported anywhere. 5500s are done for large employers, but that doesn't really tell them how much each employee is paying. So what they're really trying to figure out is how much does insurance cost, what are employers paying for this, and what percentage is that compared to how much these employees are making. So it's purely for tracking purposes. Yeah, question?
I was just wondering, for the 250 employees, is that in California? If your company has employees in other states and the total in California isn't 250, does it apply?
Okay, so it has nothing to do with state. This is federal. Oh, okay. And this is the total number of W-2s that your payroll system generates. So it's not even really number of employees because you could, depending on how much turnover you have, it's purely the number of W-2s that you just filed for 2011. The other thing that is being launched, started in January 1 of this year, is this concept of Medicare Accountable Care Organizations. So what these are, accountable care organizations, are groups of doctors, hospitals, other healthcare providers who come together voluntarily to give coordinated high-quality health care to Medicare patients that they serve. So what they're trying to do here is they have picked a number of these accountable care organizations. There's 32 organizations so far, and there's actually 3 in the Bay Area. So they may start hitting the news in a little while. They're focusing on the ones that serve Medicare patients because the government has a lot more control around the money and the care that Medicare patients receive. And what they're doing is having these organizations start looking at doing things a little bit differently. Instead of rewarding these doctors for every time someone gets put in the hospital. Let's say they have diabetes and they get put in the hospital, given some drugs, get all fixed up. They get sent home with a prescription that they can't afford. They don't refill it, and they get put back in the hospital. Instead of reimbursing the doctors every time they go in the hospital, start reimbursing them one time for taking care of them as a Medicare patient, or maybe rewarding them for keeping them out of the hospital. So they're starting to look at how they can do things differently with some of these organizations. So they're giving them a little more latitude in the way that they do things, how they bill, how they provide their care. And then the idea is at the end of the year, however much savings they can generate, the organization gets to split that money with the government. And so they're starting here. So these are kind of test programs with 32 groups. Again, not something that affects you on a day-to-day basis yet, but I think we might start getting some good information out of these groups more towards the end of the year. And then finally, one of the other things done is that preventative care guidelines for women go into effect for your renewal on or after August 1st. So this is the requirement that you provide 100% preventative care towards women's reproductive issues. So that's going to go into place with your next renewal on or after August 1st. So what are some big goals? What are some things that they're going to focus on this year under healthcare reform? These accountable care organizations, they're looking at expanding those, looking at ways that they can generate more income with them. There are some estimates that accountable care organizations can save Medicare over $960 million over the next 3 years. So some big numbers. We're going to see a lot more information coming out about that. They're also looking at addressing healthcare disparities. What this is the federal government has recognized something, and I think all of you as HR people have known for a while, that people do not, along different ethnicities, cultures, incomes, people do not use the healthcare system the same way. And what they're discovering, or they've known for a while and they're starting to try to put some teeth to, is the fact that people that don't have a primary care physician actually cost us all a lot more money in the long run. They don't go for their preventative care. They don't go when they have minor aches and pains. They wait and they go to the emergency room because they don't necessarily know how to navigate the healthcare system. And so they may go to the emergency room for a cold, or it might be stage 4 cancer. Either way, somebody ends up paying for that. And this is often, it could be that they don't have health insurance. It could be that they have health insurance, but they still don't feel that they can afford to go to the doctor on a regular basis. Or it might be that they just don't know how to access it. They get this card, they have an open enrollment meeting, they don't understand anything, and they just don't go. So there's going to be a bunch of initiatives around local clinics, communication, that sort of thing. So we're going to start seeing some more of that this year. Insurance rebates. This will be interesting. So the National Association of Insurance Commissioners estimates that if the medical loss ratios were put in place, the Americans were rebated somewhere around $2 billion for 2010. If there's actually $2 billion in rebates, I think that'll be pretty big news this year. So, and there's going to be a lot more stuff done around that. There's also a big push around electronic medical records. There's a number of dates that kick into place this year for medical groups and hospitals to have electronic medical records in place. And what they're trying to address here is the thing like you blow out your knee on a bike ride on Friday, you go see your doctor Friday afternoon, he or she says, hey, soft tissue injury, you should be fine, here's some pain reliever, and takes an x-ray, says soft tissue, pain reliever, sends you home. Well, by Saturday night, you're in so much pain you can't stand it. You go to the emergency room. Right now, in many cases, you're going to have another x-ray because they don't have that previous x-ray. So not only have you been exposed to x-rays twice, you're going to pay for them twice. And so the idea is to get everything online. The technology is there. It's really just forcing organizations to embrace those. So we're going to see a lot of stuff about electronic medical records this year. And also value-based purchasing. So with some of these new organizations, what they're going to start looking at is instead of paying fee for service, paying the doctor, let's say you have to get your knee surgery, And instead of paying you for the initial consultation, the pre-op, the operas, all the follow-up, saying, hey, we're going to give you a dollar amount for knee surgery. That's it. And so the doctors and the hospitals would be very incented to make it go well and not have you come back. And this is directly in relation to the numbers about the number of people that die and the costs due to medical errors and that sort of thing. So those are going to be some things that we're going to start seeing a lot more come out about this year. One of the other interesting things, the news has been a little exciting this year about healthcare reform. Yesterday, the New York Times has done an expose on drug firms and the amount of money that they're giving to doctors. And they put out an article yesterday where they said that they found that doctors who take money from drug makers often practice medicine differently from those who do not, and that they are more willing to prescribe drugs that are risky and unapproved, such as prescribing powerful antipsychotic medicine for children. And so one of the things that's kicking in this year is that the new law is going to require drug companies to report all gifts that they give to doctors, and these are supposed to be public records. Now, obviously, the drug companies don't want this. They say it's going to be very administratively burdensome. If we give them bagels, we're going to have to write that down. But through this report, they're showing that some of these doctors get hundreds of thousands or millions of dollars a year from these drug companies. And so there's going to be a lot of reporting about that. The law is also going to require drug and device companies to report any amount of ownership or investment that a doctor may have in their organization. And the same disclosure requirements will be to doctor-owned companies that distribute medical devices. So all of this about full disclosure, getting it out there, being honest about where the money's coming from. So those are some of the big things for 2012. So how is most of this being done? As I've talked about before, implementation of healthcare reform is being run by the Department of Health and Human Services. They have a website up, it's been up for a while, called healthcare.gov. I highly recommend, though, that all of you go take a quick look at it when you get back to your office today. So what they've done, on there for a while, it said that you could find a health plan. You put in your state, you say what kind of family, if you have a family, you have an individual, if you're a small company, what you're looking for, and then you get kind of into it, and then there'd be no actual plans. So that's been there for a while. In November, they started loading actual plan data, and they have plans in there from like 530 different insurance companies, and there's something like 27,000 plans. But if you go in, and you say you're a small employer with 5 employees and you're looking for a plan in California, it will pop up choices that will say, oh, you have a $10 copay, a $250 deductible, and it's going to cost $250 per member. Okay, so any of you that just went through your renewal know that there are not many good plans out there for $250 per member. Also, if you have an employee that has a family, it's going to be per person, so it's going to end up being like over $1,000 anyway. And so it's not beyond the realm of possibility that you could have an employee come into your office and say, hey, I was on the government website and they said I can get a plan for $250, and you're making me pay $300 a month out of my paycheck, and so I don't think you did a good job with all this insurance stuff. So how many employees will actually pay attention to that? I don't know. But if any of you have also said, oh, yeah, Aflac told me to come in and talk to my boss about coverage, just same sort of thing. Just look at it. Be aware of what's on there. There's a lot of details that aren't on there. But probably good if you're the benefits person to take a look at. Some other things that the HHS has done this year is that they have deferred to individual states the authority to define what essential health benefits are. That's a big part of healthcare reform, is that what they want to do is they want everyone to have plans that are affordable and provide a set of essential health benefits. Well, what's essential, there's a lot of money and there's a lot of politics in that, because if you are a provider that provides a service that supports something that's considered essential, that's a really good thing for you. If you do something that is not necessarily considered essential, you may want your lobby to have that determined as being essential. So they've decided to move this out to the state level. What's interesting with this is that California tends to be really, really liberal about what kind of coverage, and they want everyone to have great coverage. So on one hand, it makes it somewhat easier to feel confident that you have good coverage. On the other hand, it tends to make things more expensive. Like one of the many bills that Governor Brown signed in December said that all health plans have to provide maternity coverage. Okay, well, It may sound good that if you're a young person and you've never paid attention to your health plan, you don't want to be caught off guard and find out, ooh, I'm having a baby and my health plan doesn't cover that. But if you're in your mid-40s and you're pretty sure that you're never going to have a child ever again, you may not necessarily want to pay for that, and your employer may not want to pay for that. So this is going to be kind of fought at the state level. And there's definitely a large amount of money that's going to go into this. And I'm going to talk a little bit in a bit about why you need to continue to pay attention to what they're going to do in California. The other thing that is launching on February 1st is this new co-op loan program. The Department of Health and Human Services is going to provide low-interest loans to nonprofits that want to start their own health plan. And what they want to do is start increasing the number of plans that are in the market and can be competitive over the exchanges. So there's definitely some business opportunity there. There's also some new rules about the electronic fund transfers in healthcare. If any of you have ever worked in a doctor's office, you may know that currently when you're in a doctor's office, you send in all these claims to the insurance company for all the different services that you've provided, and then the insurance company will tend to send you back individuals' responses, kind of like we get as an EOB, as a member. And then you'll get one big check at the end of the month. So as a doctor, you have to pay someone whose whole job it is to sit there and try to figure out which money matches with which check. And so now they're putting some new rules into place that the insurance companies have to have a source code on everything, which should make the administration for doctors and physicians much more cost effective and easier to manage, which in the, each little office, you might be talking about one person, but nationwide, this may start making things a little more cost-effective to not have so much administration. So they're doing a lot of things around that. And they've also just launched something called an Innovative Advisors Program. An Innovative Advisor, they had like 1,000 applicants. I think they picked like 72 people. These are people who are involved in the medical field, be it doctors, nurses, insurance companies, that sort of thing. And they're going to be paid a stipend of $20,000 a year to participate in this program, and they're going to work together and have conference calls, and then they're going to try some new and innovative thing within their organization. They're going to go back and say, hey, we should all try this, or we should all try that. Again, kind of working with the electronic medical records, the way information's being transferred, what works, what doesn't work. So really trying to get a grip on the overall data and look at the way that we do things. So let's jump into the states. So the colors may not be as easy for you to see at each of your states, but each state is, of course, required to set up an exchange and have this in place by 2014. So the West Coast, you're kind of light blue. These are the states that have already established an exchange. Those in the red, kind of in the middle, are studying their options. Orange, Texas, South Dakota, no significant activity. They're going to go, but they haven't done anything. Those in yellow, Louisiana, Arkansas, not even going to do it. Not going to worry about it. Going to see what the government does with that. And then the slightly darker blue, plan to establish it. So currently, a lot more implementation being done on the West Coast. 26 states have filed lawsuits. They don't believe that they should have to do this. They don't like how the setting up of the exchange is being tied to their Medicare funding or Medicaid funding. So, of course, this is going to go to the Supreme Court. So California. California was the first state in the nation to implement their exchange. They are the most proactive with it. We have a governor and insurance commissioner that support the Affordable Care Act. They have set up a website. It's called healthcareexchange.ca.gov, but there isn't anything of interest on it yet. So you can go check it out. There's exchange board is going to be set up with 5 members, 2 being appointed by the governor, 2 being appointed by the legislature, and then the Secretary of Health and Human Services. So there's a 5-member board. There are conflict of interest provisions and requirements around subject matter expertise. I point that out because nobody that's on the board can financially benefit from anything having to do with the board, and they also have to really have some experience. They can't just be a political appointee. And their primary activities so far have been soliciting feedback around marketing, enrollment, IT solutions. So figuring out what platform we're going to do this on, how we're going to market it, that sort of thing. So they put out quotes or RFPs, but not much else is really happened, at least as far as what's being reported on the website. So, effect on California employers so far. Like I mentioned, the law is pretty supported by our government, so we're not participating in the lawsuit. Many of the consumer protections addressed by the law were already in place in California. So, stuff around rescission of coverage, dropping people the moment they get cancer, a lot of those protections were already in place in California, so they weren't that significant. The big one was this eligibility for children up to the age 26. I mean, that was the big one that you all had to deal with last year. The other thing that we're kind of seeing with all of this is kind of a growth in the defined contribution strategy. We're starting to see a lot more of our groups moving away from necessarily the company just paying a percentage of each plan and moving towards saying, hey, we're going to provide a base plan, we're going to pay 100% of the base plan, and then we'll have these 3 other plans, and if you want to buy up, you can. That seems to be kind of, there's a number of things that tie into that, but that sort of seems to be one of the trends that we're seeing with this. The other thing is it's still increased participation in consumer-driven plans, health savings accounts, HRAs, that sort of thing. So that's really kind of the effect that we're seeing. But overall, it hasn't been a huge change in California. There was a report on Monday in the Mercury News. So currently, right now, 36 states, the insurance commissioner in that state has the authority to do rate review and say, hey, I don't like that increase, I'm going to send it back. So California does not have that. We're one of only 14 states that the insurance commissioner doesn't have the authority to do that. Now, there's a representative, Mike Feuer, out of Los Angeles. He has put forth a bill every year for like the last 4 years to try to get this. But the insurance companies are, of course, very against this. They consider it administratively burdensome, that sort of thing. And they fight it every year. And so this year, it looks like there is a group that is going to try to get it on the November ballot. So that will be interesting. That would be something new that's going to go on the November ballot. Currently, some health insurance oversight is done with the Department of Managed Health Care and the Department of Insurance, but they're going to try to do it via a ballot. Where this is kind of interesting is that I mentioned earlier this rate oversight, that they have to have any rate reviews overseen by the Department of Health and Human Services, but the Department of Health and Human Services can't force them to not do this rate increase. They're saying now that all told, the Department of Insurance reviewed about 300 rate filings for 2011 and got rate increases reduced, postponed, or withdrawn in 50 of them. So even without the authority to force it, if they got rate reduction on 50 out of 300 increases, that's not bad. I mean, that's a start. So we will probably now see this on the November ballot. So the politics of healthcare. Like I mentioned, 26 states have filed suit against this. All the Republican presidential candidates want it repealed in some form or another. And public support of the law is mixed, depending on how the question is asked. So this is kind of interesting. I tend to follow different polls and things that they do, kind of keeping up on the politics of all of this. And there's a group called Rasmussen that what they do each week is they call 1,000 people and they ask them a series of questions. And so they'll say, who do you think is going to get the Republican presidential nomination? How do you feel about the way the economy is going? How do you feel about your job and the health insurance you're provided? And do you want a president that's a socialist and is going to turn the care of your children over to the government? So people answer all these questions, and then they'll put out some little report that says 89% of Americans don't want a president that's a socialist and is going to turn the care over of their children over to the government. And so you're like, well, duh. But then, of course, and I want to know who the 11% are, because that always strikes me as funny. Then you'll have some cable news show that'll pull up, 89% of Americans are concerned that the president is a socialist and they're going to turn their care of their children over to the government. So it really kind of depends how the question is asked. If you want to follow this at all and kind of look at this, one of the best resources is the Kaiser Foundation, totally separate from Kaiser Permanente. They're probably the biggest group to study this. And so they do a poll each year, or actually every month, about how people are feeling. And their question is, given what you know about the health reform law, do you have a generally favorable or generally unfavorable opinion of it? And so the dark blue is favorable, the kind of yellowish is unfavorable, and the gray is don't know, don't care. And so right now you'll see, as of this last month, it's pretty evenly split how Americans feel about the health care. So this will continue to obviously be a subject throughout the elections in November. But as a nation, we're pretty mixed on this. So let's talk about the Supreme Court and some of the lawsuits. So far, 26 states have filed suit. The court has overturned the law or part of the law in 3 of those, and this is at the district level. This is at the local level. The court has ruled the law constitutional or dismissed the case altogether in 6 cases. In 9 cases, they've dismissed it for lack of standing or procedure. They're saying whoever it was that brought the suit didn't have the authority to bring the suit, or they didn't follow proper procedures. And we have 8 that are pending decisions. So once a suit goes through the district court, then it, of course, moved up to the appeals court. And this is where it gets more interesting. So the courts have upheld the individual mandate on two occasions. So what they're basically focusing on is not the constitutionality of the whole law. It's the requirement that every American have health insurance, and they're calling that the individual mandate. And so they've sort of pulled this out of the law itself. So in 2 cases, it's been upheld. In 1 case, a court has struck down the individual mandate, but ruled that it did not bring down the rest of the law. And then in the 4th case, the court dismissed the case citing the Anti-Injunction Act of 1876. So that's going to get interesting. None of you have ever heard of that. I can tell by the laughs. So what the Anti-Injunction Act of 1876 says is that you cannot sue about being taxed until you have actually been harmed by the tax. And so what they're looking at is this penalty that you're going to have to pay when you file your 2014 taxes, that if you cannot prove that you have health insurance, you're going to have to pay a penalty. And they're calling it a shared responsibility penalty. So you're going to have to pay more, or you'll get less back when you file your taxes. Now, they're saying that this is not a tax, but this group is saying, yes, it is. It's coming out of my taxes. I get more or less taxes. This is a tax that you're making me pay because I don't have health insurance. Well, then this party is saying, well, then you can't sue about this until after you've actually been harmed by the tax, which actually sort of works in the Obama administration's favor, though this is not necessarily their argument because they don't want to be tied to any more taxes. Nobody does. And so it really is going to come down to whether or not this is a tax. If they deem that it is a tax, then no one can sue about it till actually they've been harmed by the tax. So that means you can't sue until you've actually paid it, which is going to be in 2015 after you've done your 2014 taxes. And then I'm not a tax professional, but I think there's somewhere in there that you have to send some paperwork to the IRS saying this. You have to pay it. You have to say this is all unfair. The IRS has something like 6 months to get back to you. After that, you can start your lawsuit process. This could go to 2020. I mean, this could go forever. So there's this Anti-Injunction Act of 1876 that is also going to be a significant part of this case. So the Supreme Court has decided to take on the Florida case, and what they're going to look at is 3 different factors actually 4 different factors over a 3-day period. So this case is going to start on Monday, March 26th, and the first day is going to focus on whether the tax injunction or the Anti-Injunction Act bars the justices from making a decision until after the law goes into effect. So there is a chance the Supreme Court is going to see it, going to hear the law on the first day and say, we're punting this down the road. We have no authority you had no authority to sue. We have no authority to make a ruling. So that's going to be the first day. The second day, they're going to take up the constitutionality of the law's individual mandate. Is it unconstitutional to force Americans to have health insurance? And then on the third day, they're going to look at whether the individual mandate is so central to the law that if they determine that is unconstitutional, the whole law goes away, or whether the law will stay in place and they're just going to take out the individual mandate. So they're going to look at this over 3 days. And then on the 4th day, also on Wednesday, the states are claiming that the law improperly expands Medicaid by tying states' receipt of federal funds to the participation in the new exchange system, which is all the big state lawsuit. Nobody actually thinks that that's going to win because there's a whole bunch of stuff that's already tied to Medicaid funding, but the court's going to also consider that on the Wednesday. So what are the arguments? Okay, so those that are suing, those that are against the Affordable Care Act, are really against the individual mandate. And they say that this is a massive overreach of Congress's power to regulate interstate commerce. They're saying that, well, the law gives Congress the authority to or regulate interstate activity, it doesn't give them the authority to regulate inactivity. Inactivity is, hey, I don't want to buy health insurance. I'm not doing anything. You have no right to make me do anything. The people that are the Obama administration, who's filed one brief, and there'll be a series of briefs that are filed before the court actually goes into session, is saying that this is not about health insurance. This is about payment for the health care system. And all Americans already actively participate in the health care system. If you were born in a hospital, you already actively participate in the healthcare system. And if bills are not getting paid in our overall healthcare system, it does affect interstate commerce. So yes, we do have the authority to regulate payment for participating in the healthcare system. So that's kind of the fundamental question. It's not, and so it's really about, is this about health insurance or is this about the healthcare system, and how much authority does Congress have? So some predictions. No one can predict what the Supreme Court is going to do, or any courts really. But the Obama administration is feeling pretty confident about this. I mean, they actually, when Florida filed suit and put a brief to the Supreme Court, the current administration asked that it get moved up and get resolved before the next election. So by most words, they're feeling pretty confident about this. Most experts, and experts, being people that want to write about this stuff, don't really think that the whole law is going to be shut down. They think it's either going to be, the decision's going to be punted for a few years, or they may pull out the individual mandate, but they don't expect the entire law to be thrown out. It'll probably be a close decision. The court is pretty split. We have 4 conservatives, 4 liberals. Justice Kennedy will probably be the deciding vote. That happens a lot now. And it may depend on how strong the president looks in March. I mean, politics always plays into this. So we'd like to think, the Supreme Court is, kind of a separate little entity. You're purely looking at the law, but of course politics kind of enter into this. And again, they could just decide to punt the decision for a few years and not make a decision. So if it is upheld, or even punted down the road, I guess, the law will go forward as planned. Of course, there's many conservative Americans and politicians that won't be happy about that. But if it is upheld, it will go forward. Republican efforts to repeal or defund the law will continue to be symbolic without the control of the Senate or the White House, which of course could happen in December. Right now, currently, I'm sure that all of you know that Republicans have strong control of the House of Representatives. The Democrats control the Senate. We have a Democratic president. In November, the control of the Senate will definitely be in play with the November elections. Here's the thing, though. Even if there is a bit of a swing and the Republicans take control of the Senate, they really have to have a supermajority. They have to be able to get 60 or more votes to get a lot done. Because in the Senate, there's this concept of a filibuster, where basically one senator can hold up the whole thing if they want to, unless they can get 60 votes. No one is projecting that either party is going to sweep enough. No party appears to be loved on any level that there's going to be any big sweep. So even if the Republicans do take some control of the Senate, they're probably not going to have the authority to repeal it, because again, they would have to have 60 votes. The one thing that they may have working for them is that you only need 51 votes to do something called a budget reconciliation bill. And a budget reconciliation bill can't be filibustered. And so what a budget reconciliation bill would be is it's not going to let them repeal the whole law, but it will let them attack various parts of the law that affect the budget, the subsidies that are going to go to low-income people, that sort of thing. They would be able to attack parts of that and really chip away at the law. But they're not going to be able to repeal the whole thing, because things like the fact that insurance companies can't discriminate with pre-existing conditions against children, they can't really repeal that because that has nothing to do with the federal budget. So even if they start picking apart this, it doesn't mean that the private sector, you as an employer or insurance companies, aren't going to be left footing the bill for this. So it'll be interesting. So if the law is upheld, they may chip away at it a little bit, but it's not going to go away. And if they tried to do the whole repeal, they'd actually have to figure out how to pay for it, because the Congressional Budget Office has actually said that in the long term, this bill is going to save money. So if they want to repeal it, that's actually going to spend more money. And so again, unless they get a big, massive wave of Republicans into the Senate, they're probably not going to be able to get rid of the bill. And even defunding it, even when they talk about that, is probably not all that likely. So what are our November scenarios? One, let's say Obama does lose. We get a Republican president, and Republicans take the Senate by a lot. They get their 60 votes. Healthcare reform is toast. They're going to want to repeal the bill. But interestingly enough, you're not going to wake up the next morning and it all goes away. So, because as an employer, you already got the plan you have, and you have it for the year. Your insurance companies have already put in the changes that they've put in. California has already put in the regulations. The IRS, the Department of Labor, all these regulations don't just go away. And so, if it is truly repealed, again, you don't wake up tomorrow and it's like it was in 2009. There's going to be a lot of stuff that will still have to be figured out about that. The next scenario, which is probably a little more likely, is if Obama loses and the Republicans take the Senate by a little, health reform stays into place, but it probably loses some big chunks. There's going to need to definitely be some compromise. Scenario 3, Obama wins and the Republicans take the Senate. Again, healthcare reform muddles through. You'll still have a Democrat president that would veto any kind of repeal, so the law will stay in place, but all the money is generally controlled in Congress. And so if the Republicans had both House, reform will exist, but they muddle through. But if Obama wins and Democrats keep the Senate, health reform lives. All the posturing, all the yelling on cable news, the law stays. So we're going to just keep moving forward with it. If it is ruled unconstitutional, it really comes down to, if it's ruled unconstitutional, it really comes down to whether or not they decide that the individual mandate can be pulled out or not. So if they say, no, the individual mandate is unconstitutional, it is so critical to the law that it can't be pulled out, the whole thing will be struck down. If they decide that the individual mandate is unconstitutional, but it is not so critical to the rest of the law will stay in place. It's just that insurance companies are now going to be forced to cover everyone, but everyone doesn't have to get insurance, which is kind of the funding for the whole thing. So the law would stay in place, and basically Congress and the president would have to work together to figure out how to pay for it, which is a little scary this year. But so the law would stay in place with no funding source. And a loss at the Supreme Court does not necessarily indicate a loss in November. So they're going to hear this case in March. We will probably get the ruling sometime around June. Everyone goes to the polls in November. By conventional wisdom, I guess that you would think if Obama loses the Supreme Court, that's going to make him weak. His signature achievement is going to be shot down. He's obviously going to lose in November. But I wouldn't say that that is necessarily the case because, like I said at the very first slide, a lot of consumer protections have been put into place. So if this law gets shut down, it would be very easy for the Democrats to really start rallying. Look at those big, bad Republicans. They take away coverage for your children. They want to exclude your children that have cancer. Seniors, they're going to take away the Medicare benefits that we've given you. So I think it will kind of really energize their base. Same thing on the Republican side. Now that, if Obama wins, he's obviously going to claim victory. See, I was right all along. The nation agrees with me, but nothing's going to energize the Republican base as much as losing in the Supreme Court. So I still think that, they may be 2 and 4 months between decisions is a really long time, in the American attention span around politics. So I think there'll be definitely 2 significant and separate events. The one doesn't necessarily tie into the other. Until then, by all studies, most employers do not plan on dropping coverage. Everyone's kind of taking a wait and see. Let's see what these exchanges look like. We're definitely still seeing that health management programs, wellness programs, coupled with incentives are going to still be your best bet around trying to control costs. The government's not going to take care of this for you. You're going to have to do it within your own organization. And pay attention to the development of California's exchange. A version of this exchange may stay in place whether or not this law gets shot down or not. As a California employer, you may still be working with some sort of exchange in 2014. So it's worth following a little bit. All right, so from an employer perspective, there's nothing you really need to do this year. Just kind of follow the news and see what everybody else does.